On behalf of the Latin American Society of Internal Medicine, it is an honor for me to introduce Professor Dr. Marcos Maurer. Professor Dr. Marcos Maurer is a world expert on the subject of urticaria and allergy issues. El profesor Dr. Marcos Maurer es catedrático de dermatología y alergia en la Universidad de Charity de Berlín. Es director asociado de Allergy Centrum Charity, jefe de las especialidades de urticaria, mastocitosis, prurito, angioedema hereditario del Laboratorio de Alergia y Dermatología. Es director de investigación del Departamento de Dermatología y Alergia, jefe de clínicas de mastocitosis, prurito, angioedema. Tiene un entrenamiento en patología en Beth Israel Deacon's Hospital and Harvard Medical School en Boston. Es un miembro certificado de las sociedades y colegios de dermatología y alergia, experto en investigación en mastocitos en la Universidad de Mainz, responsable de la red de urticaria, coordinador del Programa Nacional Prioritario de Funciones Fisiológicas de los mastocitos, responsable del Grupo Galen sobre urticaria y el programa COST sobre mastocitosis y basófilos. Miembro de la Junta ECARF de la Fundación Alemana para el Servicio de Información sobre el Polen. Es autor de más de 400 publicaciones en revistas de alto impacto y autor de más de 40 libros y capítulos en libros. Gracias, doctor Maurer, por estar con nosotros. Adelante con la ponencia.
Muchísimas gracias. Es un honor y placer de estar contigo, Ariel. Thank you very much for your invitation. It is very exciting to share new insights on urticaria and hereditary angioedema with you today. Now, I will start with my lecture on chronic urticaria, if that's good. Right. Then thank you again very much for your kind words and the introduction, Ariel. It's a true pleasure to be with you. And I will start with new insights on chronic urticaria, the approach to the management and treatment. These are my conflicts of interest. Let us start from the beginning, because I will bring to you the just published update of the international guideline, and some things stay the same. The classification, for example, still is, if you have it for less than 6 weeks, well, then it's acute urticaria. If it's more than 6 weeks, that makes it chronic urticaria. And we will focus on chronic urticaria, specifically on chronic spontaneous urticaria, which is the most common form. We will talk about the underlying causes, about the diagnostic workup, and about how to treat patients with chronic spontaneous urticaria. And that is not to say that chronic inducible urticaria is not important. No, it is. But we will focus today on spontaneous urticaria. 1% of the general population today has chronic spontaneous urticaria. And what problems do these patients have? Well, they have very itchy wheals, like you can see on the left, ronchas, or they have angioedema on the right. In fact, most patients have both. There are 3 groups. You can have only wheals, no angioedema, it's about 30 to 40%. You can have wheals and angioedema, 50 to 60%. And then there's 10% of patients with chronic spontaneous urticaria who have angioedema only. And I want to say 2 things about this angioedema. It is very frightening, but it is not deadly. There are forms of angioedema that lead to suffocation. In chronic spontaneous urticaria, this is not the case, but often our patients don't know that this is not dangerous. We need to tell them. Why? 70% of patients with this disease have angioedema, and most commonly the lips, the eyes, in the face. Certainly annoying, but not dangerous. Now, why do patients get chronic spontaneous urticaria? Well, they get this because of the mast cells in their skin becoming activated, releasing pro-inflammatory mediators, including histamine, that then lead to itch. extravasation, that's the wheals and angioedema, vasodilation, that's the redness of the skin, and an infiltrate that when we do a biopsy has eosinophils, basophils, and T cells. So the true question is, what do these people have who get chronic spontaneous urticaria? Why do their mast cells get activated? What is the signal? And we know that unlike allergy, this is not an allergy. You do not get chronic spontaneous urticaria because you're sensitized to pollen or to peanut or to house dust mite. You get allergies from it, hay fever, food allergy. Now, what makes mast cells degranulate in chronic spontaneous urticaria? There's two ways mast cells become activated. One is actually by IgE, but not IgE to allergens, IgE to autoallergens. So these people are truly allergic to themselves. We call this autoallergic or autoimmune type 1 chronic spontaneous urticaria because they're IgE autoantibodies to internal endogenous antigens, autoallergens. This is the bigger group of patients with chronic spontaneous urticaria. The smaller group has autoantibodies that go directly to the mast cell and activate the mast cells. IgG against IgE bound to the surface of mast cells, or IgG to the IgE receptor. We will see why it is important to distinguish between type 1 and type 2, but the main point is we know what causes chronic spontaneous urticaria. Now, if you treat patients with chronic spontaneous urticaria, you can explain to them that they have this because of an autoimmune disease. There's no use in allergy testing. You will never find the allergen that causes chronic spontaneous urticaria. But your patients will tell you, Doc, this is especially bad when I'm stressed. Doctor, I have this especially bad when I have an infection, or when I eat something, or when I take aspirin. And this is all true. And we think of it this way. You know, you have mast cell degranulators, and then you have things in the environment that make mast cells more likely to become activated. And what this means is that it's a very fluctuating disease where one day can be really bad and the next day can be okay. And then the next day is bad again, depending on the presence of triggers. No? Stress, food, drugs, infections are not the cause of chronic spontaneous urticaria, but do influence disease activity. So, what do we do when a patient with chronic spontaneous urticaria comes to us? The guideline says we should do 7 things. We call it the 7 C's of chronic spontaneous urticaria diagnostics. And what are they? Well, first of all, we should confirm that this is chronic spontaneous urticaria. Why? Because there are other diseases that come with wheals or angioedema. They're not as common as chronic spontaneous urticaria, but think of hereditary angioedema comes with angioedema. Think of Schnitzler syndrome or urticaria vasculitis comes with wheals, but is not chronic spontaneous urticaria. And then we can do tests to identify type 1 and type 2 patients, because this guides our expectation on treatment. We should also look for comorbidities, consequences, cofactors, components, and the course. I will come to that in a minute. But first, let's look. Why is it important to know whether a patient has type 1 on the right, autoallergic, or type 2B? Well, these two groups are quite different. The type 2B patients have high disease activity, often have other forms of autoimmunity, Hashimoto, for example. They have elevated inflammation markers, and they do not respond well to treatment, not to antihistamines and not to omalizumab. The type 1 patients have a higher rate of allergy comorbidity, and they respond fast to antihistamines and omalizumab. How can you diagnose someone to have type 1 and type 2B autoimmune chronic spontaneous urticaria? Well, the best test for type 2B is a basophil activation test, which many of us do not have. So Just in routine clinical practice, you can do two things. You can look for low IgE and for IgG to TPO. If both of these are positive, it is very likely that this is a type 2B, difficult to treat, long duration chronic spontaneous urticaria patient. What comorbidities should we look for? 20% of patients with chronic spontaneous urticaria have another form of chronic urticaria, chronic inducible urticaria, cold urticaria, cholinergic urticaria, contact urticaria, symptomatic dermographism. All of these inducible urticarias are more common in patients who have chronic spontaneous urticaria. And we already heard about autoimmune diseases, more common in CSU because it is also an autoimmune disease. Now, this disease is really bad for your mental health, and that's why 30 to 40% of patients have depression, panic disorders, anxiety, mental health issues, and it's an important issue to address in routine clinical practice. Now, what do I mean by we should look at the course of the disease? This is very important for routine clinical practice. We need to assess disease activity, impact, and control. And yes, we can do this by a conversation with our patients, but we really should do this by the use of tools, instruments, questionnaires. These are short tools, 4 questions, 5 questions. And disease activity we assess by the UAS, Urticaria Activity Score, or in patients with angioedema, the AAS, Angioedema Activity Score. Available in Spanish, in many country languages, so easy to complete for your patients in their own language. Quality of life, you can assess with the KUQOL or the IAQOL, disease-specific questionnaires. But here are the most important ones, the UCT and the ECT, the Urticaria Control Test and the Angioedema Control Test. We use these in all of our patients. Why? Because they answer the question, is your disease under control? And that's really the most important question that we have to our patients. Do we need better treatment, or are you in control of your disease? And the way the Urticaria Control Test does this is really super simple. It takes less than a minute for patients to complete this test. 4 questions. For each question, there are 5 possible answers. These answers will give your patient between 0, no control, to 4 points, maximum control. 4 times 4, 16. Once the patient reaches 12 points, that means they have okay control, well-controlled disease. Of course, you want to bring them to 16, but with 12 points, they have their disease under control. Now, the angioedema control test is the same only for angioedema. Again, 4 questions, 5 answer options, 16 points maximum. And here the threshold is 10. So with the UCT, you need 12 and higher. With the ACT, you need 10 and higher. And why is this important? Because I know this can be a difficult to treat disease. I know that these patients can be difficult to manage. They come to you and the disease is in control of their lives. You want to turn that around and bring control to the patient. In fact, we say, treat the disease until it is gone. This is what guides us in our treatment approach. And what does that mean? Chronic spontaneous urticaria always goes away in all of our patients. We don't know exactly for the individual patient when this will happen. In most patients, it takes a couple of years. And until it happens, until spontaneous remission occurs, we want to give complete control to our patients, have them live normal lives, have them not have wheals, itch, angioedema. Treat the disease until it is gone. How do we do that? The very recent version of the guideline has 3 treatment steps. Step 1, an antihistamine. And you all do this when you treat chronic urticaria. You give your patient a modern, non-sedating antihistamine. No one uses the sedating ones anymore. They're not better. In fact, they're worse because they make people tired. And even when they make people tired and you think that's a good idea because then they can sleep, Their sleep is not good. So please don't use the old sedating antihistamines anymore. We should use the modern ones. But we also know that not all patients respond to your favorite antihistamine when given at standard dose. So the guideline in the first step already includes, well, if the standard dose doesn't work, you can and should go up to 4 times the standard dose, 2 tablets in the morning, 2 tablets at night. This is the first step. We know that many patients benefit, but we also know that many patients do not. So we need to step it up. We measure with the UCT or the UAS or the ACT or the AAS, and when they don't reach control, when they still have signs and symptoms, we move to step 2. What is step 2? There's only one drug in step 2, and that drug is called omalizumab. Omalizumab is a chronic spontaneous urticaria drug and an asthma drug. So we have plenty of experience with the use of omalizumab. It's very effective, it's safe, and you can give it long term. Omalizumab at the beginning is given 300 milligrams as a subcutaneous injection every 4 weeks. But when that doesn't work after 3, 4, 5 months, we should shorten the interval or use a higher dose or do both. Now, we talked about type 1 and type 2 autoimmune chronic spontaneous urticaria, right? These 2 first steps work much better in the type 1 chronic spontaneous urticaria patients, the one with the IgE, the one with the autoallergens. They do not work so well in the type 2 urticaria patients. And when they work, it takes a longer time for these patients to respond. Again, you can screen for them. They have low IgE, they have elevated IgG anti-TP, or if you have access to do a basophil activation test, they will be positive. These patients, they don't respond to the omalizumab, are the ones where we consider step 3. What is step 3? We don't want cortisone. Cortisone does not have a place in the long-term treatment of chronic spontaneous urticaria. But we need to then go to immunosuppression. And the immunosuppressive treatment we use is cyclosporin. Well, we need between 2 to 5 mg per kg, but that is something that is not standardized. Point is, when step 1 doesn't work, we go to step 2. When step 2 doesn't work, we go to step 3. And we don't stop here. If step 3 also doesn't work, well, we try to find other solutions for our patients, but these 3 are evidence-based, and 2 of them, step 1 and step 2, are licensed for the treatment of chronic spontaneous urticaria. Now, the new guideline uses this algorithm, but it doesn't say this is a once-in-a-lifetime decision and then they stay the same. No, just like in other chronic inflammatory diseases, we need to be ready to step up and then step back down depending on the disease activity. So we assess, and that's by using the UAS or the UCT, the tools. And if we're happy, good. If we're not happy and the patient is not happy, we act. And that is, we increase the dose, we go to the next step, we shorten the interval, we adjust to bring control to our patient. And then we assess again. And the rule of thumb is, if you have a patient who has a UCT of less than 12 on the left, this means uncontrolled, and we need to do more in this patient. On the other hand, if you have a patient who for a long time has achieved UCT of 16, you can think about stepping down. Maybe the disease is no longer there. The in-between ones, we need to optimize. So once you've reached 12, let's work to get this patient to 16. In my last 2 minutes, I want to show you that the future of chronic urticaria and chronic urticaria management is very bright. We have here the main players of the pathogenesis of chronic spontaneous urticaria. Mast cells, of course, that get activated by autoantibodies coming from B cells that learn how to make these autoantibodies from T cells. And there are many receptors on the surface of mast cells and many mast cell mediators that come into play in chronic spontaneous urticaria. So new treatment that is currently already in clinical trials focuses on mast cells. What can we do? We can inhibit the mediators, and that is use an antihistamine or block another mast cell mediator. We can inhibit the activation, for example, IgE. And omalizumab does just that. New anti-IgEs are coming, ligelizumab and others. What we can also do now is silence mast cells and make them unresponsive to triggers of activation. And we can even deplete mast cells in humans. And the first trials have shown that this is very effective in the treatment of chronic urticaria. So there are more management options to come to us. I hope this gave you a quick update of chronic urticaria, what we do and what we're looking forward to. Please check out the UCare network. This is a global network, more than 120 centers that work together to investigate urticaria, provide best practice in urticaria. So go check them out and see how you can join and be a part of this global network. Please also consider to donate your urticaria data. If you see patients with urticaria, you can enter the data into CURE, the chronic urticaria registry. CURE is open for everyone. We already have more than 4,000 patients with chronic urticaria documented, and for sure, this will teach us why patients behave the way they do, why some patients have long disease, others have short disease, why some patients get angioedema, others get wheals, and yet others get both of this. And with this, thank you very much again to the organizers. Thank you for your attention. And with my best wishes from the UCare, the Urticaria Center of Reference and Excellence, and the Angioedema Center of Reference and Excellence here at Charité in Berlin. If you have questions, I left my email address here on the bottom right, markus.maurer@charité.de. You can always email me with difficult patients or interesting questions. I'll be happy to help. Thank you very much.
Thank you very much for your excellent presentation. Muchas gracias, profesor Maurer, por esta excelente presentación y por ampliarnos el panorama de urticaria para los internistas que a veces no manejamos tan bien el tema de urticaria, pero que hemos tenido muchas perspectivas y muchos acercamientos más importantes a la urticaria. Muchas gracias.
Ariel, I've also prepared a little lecture on hereditary angioedema that I will share with you now. Hereditary angioedema is very close to my heart because this is a very bad disease to have. As you all know, it's a genetic disease, so it comes in families. And I started treating patients with hereditary angioedema many years ago. So I'm actually treating whole families, the grandmother, the mother, and now the young daughter. And it is very important that patients with this disease get good care. So I want to share with you some of the recent insights on hereditary angioedema. Again, these are my conflicts of interest. And we also have a world guideline on hereditary angioedema that is just now also coming out. It's the second update and revision. It was made entirely remotely. Usually we meet to do this, but here we had a Delphi process, an international online consensus finding. This is the VAO and EACI guideline, 59 experts from 39 societies in 27 countries. And I will share with you some of the 28 recommendations, including new recommendations that for the first time are now in this version of the world guideline. Now, for those of you who have not seen a patient with hereditary angioedema, it's a rare disease, 1 in 50, 1 in 60,000. Let me just remind you again, rare disease, very disabling, potentially fatal. People still die from this disease and undertreated. And what does it look like in patients? Well, they get swellings, angioedema, usually a little bit longer, 2, 3, 4 days if left untreated, of the hands, feet, genitalia, of the mucous membranes, so the tongue, and it doesn't stop at the tongue. In urticaria, the angioedema, tongue, but not further. In hereditary angioedema, it does go further. Upper airways, larynx, suffocation, so there is danger of death. It also comes with abdominal attacks, very vicious because these are super painful. Oh, the gut closes and you go into an abdominal colic that can last for days. And many patients take a long time before they're diagnosed with hereditary angioedema. And of course, when the upper airways, we talked about this, are affected, it becomes very dangerous. So we must see that in our field, allergology, hereditary angioedema, although it's not an allergy, patients come and they think it's an allergy, and many doctors think this is an allergy, is one of the most deadly diseases that we get to treat. Now, patients go from looking like they do on the left to looking like they do on the right within a couple of hours, and they stay that way, and it can go down to the upper airways. So it is important that we diagnose early, give them the correct diagnosis, and of course, provide treatment, protection by prophylaxis, and on-demand rescue medication that they can use when they have such an attack. How often do patients with HAE have attacks? Well, quite often. As you can see here from 3 different countries, most patients have their attacks more than once per week or once per month. So after the attack is in some way, for most patients, always before the next attack. And the fear that comes with it is tremendous. Once you've had laryngeal edema, you are always afraid that this will happen again. You don't like to go to sleep because you don't know if you will be waking up in the next morning. Patients have a lot of anxiety and a lot of fears. They become very sad with their situation, depressed. And of course, they are afraid that they will die, that they will get these very painful abdominal attacks and pass on their disease to the children, which in 50% of children happens. So it's important to look at these children early on to make sure that we know who has and who does not have the disease. Now, it is very clear, therefore, that there's a significant impact on the patient's life and on the whole family's life. No? Many patients who have this disease do not do what they would like to do in their free time, in their job. They don't travel, they don't exercise because they're afraid that they will get an attack and possibly die from it. Now, we've been able to treat for a long time. C1 inhibitor has been around for 50 years in many countries, androgens also, but we have to see that these are not the state-of-the-art treatment options when it comes to protecting patients from our disease here. So C1 inhibitor is licensed for this, and we'll talk about this a little bit, but it is, when administered, something that you have to give right away in an attack and twice per week to protect. Yeah. These abdominal attacks, they do not reveal anything when you open the patient up. Now, many patients have surgery because surgeons think there's something wrong with the gut that we must fix, and they're cut open, but nothing is found. Many patients have prodromal signs and symptoms. In other words, they know when the next attack will come. And this can be irritation, this can be them getting hungry or angry, but you can also, in many patients, see this. No, this is called erythema marginatum, and it's not urticaria. No, it's just redness that comes from the bradykinin that makes the attacks come, and you have this erythema right before the next attack, within hours. Now, here's a child with this sometimes called chicken wire exanthema, very, very pointing to an attack and to hereditary angioedema. The attacks that these patients have are usually longer days, and it's an early onset. No, when you have chronic spontaneous urticaria and angioedema, you usually get this as an adult. When you have hereditary angioedema, you usually get your first attacks as a child or an adolescent. Look, these are all patients with hereditary angioedema and the age of onset when they had their first attack. So you can see that almost all patients had their first attack before they became adults, many of them before they became 10 years old. And finally, and there is a family history, and you should always ask all patients with angioedema, does anyone else in the family also have this or had this? Well, if they say yes, then that's a very, very good pointer to hereditary angioedema, especially in patients who do not have wheals. So what do the guidelines recommend? We should look at these patients. We should diagnose these patients. And we do this by looking at C1 inhibitor, which is what these patients, because of the mutations that they have, are lacking. So what we need to do is measure C4, C1 inhibitor levels, and C1 inhibitor functions. Only 3 tests. And with this, we can diagnose most cases of hereditary angioedema. There are a few cases where it's not C1 inhibitor, where we need genetic analyses, and this is done at angioedema centers of reference and excellence, for example, or university hospitals. But most patients with hereditary angioedema, with 3 tests, you can diagnose: C4, complement C4, C1 inhibitor level, C1 inhibitor function. That brings us to the treatment. What do we do when we have identified a patient with hereditary angioedema? And the guideline is very clear on what we should aim for. The guideline says we recommend that the goal of treatment is to achieve total control of the disease and to normalize the patient's lives. In other words, we do not want hereditary angioedema patients to have less attacks or shorter attacks. We want them to have no attacks, no peripheral, no laryngeal, no abdominal attacks. And how do we achieve that? Now, in order to protect our patients, we need to initiate treatment that doesn't allow attacks to occur. No, it's different from providing patients with C1 inhibitor or icatibant to treat an attack. This they should always have. That's rescue medication. No patient should walk without something to control an attack when it happens, even those who are on prophylaxis, because breakthrough attacks can happen. But what we should do is have our patients consider to receive long-term prophylaxis. And there are 3 modern treatment options. All of them are first-line long-term prophylactic treatment options. The first one, but in no particular order, is plasma-derived C1 inhibitor, which gives them back what they're lacking. The second one is lanadelumab. What is lanadelumab? It's a kallikrein inhibitor. Remember the contact system? It starts with factor 12, and then pre-kallikrein becomes kallikrein to go to high molecular weight kininogen, and that's what makes the bradykinin. It's an avalanche, a cascade, a system that results in bradykinin, and bradykinin makes the swellings. If you stop it by C1 inhibitor or by blocking kallikrein, then bradykinin can no longer be formed and patients are protected. And this is exactly what lanadelumab does. It's a subcutaneously applied every 2, every 4 weeks antibody to kallikrein to stop the formation of bradykinin. And berotralstat, very new, we only got it a couple of months ago, is also a kallikrein inhibitor, but given orally. So you have 3 treatment options. I do hope that they're available, or at least one of them is available in your country to your patients. If not, let's make that happen soon, because this is the world guideline recommended first-line treatment for patients with hereditary angioedema. Now, hereditary angioedema, because it is so dangerous, and also because, well, it can be complex and is rare, should be treated at centers that have experience with the treatment of this. And this is why we encourage that angioedema centers are involved in the treatment of hereditary angioedema patients. And these centers, they do use long-term prophylaxis, and they do routinely monitor for disease activity, impact, and control. Well, you remember those from the urticaria story, where we also look at disease activity, impact, and control. In fact, we use the same tools. We use the angioedema activity score, we use the angioedema quality of life questionnaire, and we use the angioedema control test in patients with hereditary angioedema and in patients with other forms of angioedema, like angioedema in chronic spontaneous urticaria. But what is important is to think of our treatment aims as the target. What do we want? We want no attacks in our patients. We want complete control in our patients, and we want a normal life. So the target of our treatment is right here, where these three things overlap, where patients have all three: no attacks, complete control, and a normal life. And the AAS and the IAQOL and the IACT, they help us to monitor for this. Have we reached our treatment goal? And just to review again, these are 4 perfect questions in the angioedema control test that tell you that there is or is not a need for improving the treatment. No? How often have you had angioedema? How much has your quality of life been affected? How much has the unpredictability of angioedema bothered you? And how well has your angioedema been controlled by your therapy? Those are the 4 questions we need to ask patients in order to know where they stand, and in order to provide the treatment that they need. Now, we talked about this. It's very easy to calculate. No, all you have to do is add up the points for these 4 questions. 16 is the maximum. 10 is where you want to get them. And to achieve that, if need be, all patients should be receiving integrated, comprehensive expert care. This is very important because many questions come up during the life of an angioedema patient. No, they go into puberty. Things change. They are thinking about what they should do with their lives, what career to choose. That's very difficult to decide when you know that you have swellings that can appear. They think about having kids or not. We should help them to make that decision by providing good information. They will get sick and may need surgery. How do we do this? How do we manage these special situations? They do get pregnant, and that can change the course of hereditary angioedema. You see where I'm getting at. It is important that we have angioedema specialist centers that care for these patients, and that finally brings us to ACARE, the Global Network of Angioedema Centers of Reference and Excellence. Now, these centers work together to investigate hereditary angioedema and other forms of angioedema. They educate patients and physicians. They establish treatment algorithms, and they make guidelines. So check it out at www.acare-network.com. See what they do, see what they can do for you, and join their efforts. Look, I want to summarize in my last minute the salient points about hereditary angioedema. It is very dangerous. It can be hard to diagnose, so keep your eyes open for family history, prodromes, abdominal attacks. When you have suspicion, look at C4, C1 inhibitor. That is the diagnostic approach. And when you identify a patient with hereditary angioedema, go to all the family members and be sure that you're not missing another family member who has the disease. Also, make sure that you work with an angioedemologist if you want. No, an angioedema expert, whether this is an ACARE or another center, they can provide the care that sometimes in clinical practice is so hard to give to these complex patients. But most of all, we must get modern treatment options to all patients with hereditary angioedema in Bolivia and South America and in all of Latin America, everywhere. And we know that this is not the case as of now. There's a huge disparity where in some countries we have all of these treatment options we can choose, and in other countries we only have the old androgens that we don't want to use anymore. So let's work together as a global community, together with the patient network, Hereditary Angioedema International, together with lawmakers, reimbursement agents, hospital administrators, to find ways to bring these modern treatment options to all patients everywhere. In the end, we can only do this together, us in academia, in clinical practice, with industry, and everyone else who is involved, most importantly, the patients. So I wish that your next diagnosis of a hereditary angioedema patient coming to you is quick and correct, and that you rely on the guideline recommendations for treatment, and that is to, well, treat the disease so that there are no more attacks, a normal life in your patient to achieve complete control. And with that, thank you again from the A-Care and U-Care here at Charité. Again, my email address is on the bottom. If you have questions, I'll be very happy to answer them. If you have difficult to treat patients, do let me know. We're always happy to help. Thank you again to the organizers. Muchísimas gracias. Un honor y placer de estar contigo. Gracias.
Thank you very much for your excellent presentation. Gracias por la excelente presentación, profesor Maurer, y es un gusto tenerle en el Congreso. Y es un honor también para nosotros que esté acá.